the patient is young, patient is active sports person, and in this case the patient is an active fast bowler. And now coming with back pain symptoms. So it's a common scenario in young children, adolescent population, when they are doing extreme sports activities such as weightlifting, throwing activities such as fast bowlers, gymnastics, and these put a lot of pressure and stress changes on the pars and lead to pars stress changes, pars stress fractures. And this is one such case where we will discuss the pars changes in these patients and the different types of sequences that are employed in these cases, and how CT can also be used in problem solving. And then we'll also quickly look at the different grading systems. So starting with this case, this is a sagittal T2 fat saturated sequence, and on one of the sides we can clearly see that there is bony edema, there is a gap between the pars, that means there is a pars defect. There are soft tissue and bony edematous changes, and clearly on this side there is a lot ongoing. So pars stress fracture which is established, and there are bony and soft tissue edematous changes. Now the next thing we look for is in the center, we try and look to see if there is any listhesis. So there is no slippage as yet, there is no spondylolisthesis. And then as we come on to the other side to check for stress changes, we think on this particular sequence, which is T2 fat saturated, that the pars is all intact, and particularly there is no bony or stress, soft tissue edema stress changes. So all the changes are centered on one side, and the other side appears quiet and normal. So now let's look at the same thing on the T1 vibe sequence. So this on the right side is the T1 vibe sequence, and on this one, the side which appeared quieter and normal, where there is no edema in the bone or soft tissue, and where the pars appears to be in continuity on the T2 fat saturated sequence. But on the T1 vibe, we can clearly see that there is a pars defect. There is no significant gap here, but clearly there is a pars defect. So this is how the T1 vibe sequence can be very, very useful in these cases, particularly as it picks up the anatomy quite well. And now when we go on to the other side we had seen a definite pars defect and a lot of bony and soft tissue edematous changes. And as we go on to this side, clearly we can see that there is a pars defect with slightly irregular margins, and there is gap. We can even measure the gap at the site of the pars defect, and we can see the bony anatomy. So all these changes are extending medially into the center and towards the posterior element in the middle, that is to the lamina and the spinous processes regions. So all these changes are extending all to that areas. So now next thing we will do is look at the axial sequence. So on the right side is the axial T2 non-fat saturated sequence, and I think this is just to show you the anatomy again, but in the absence of fluid sensitive fat saturation, it becomes difficult to pick up these abnormalities. So one of the sequences which is then employed is called as the pars specific sequence. So let's look at that particular sequence. So this is the coronal oblique T1 non-fat saturated sequence on the right side, and this is coronal oblique. The oblique is along the pars, along the pedicle and the pars, and these help pick up the abnormalities in the pars much more clearly. So as we look here, we can see that there is a pars defect in this area, and the pars defect is extending centrally and medially, which we can see very clearly. And next thing we will do is look at the same sequence as a T2 fat saturated sequence. So this next one here is the T2 fat saturated sequence. So on this one, which is the pars sequence again, this is the coronal oblique again, and then we can see the bony edematous changes in the region of pars defect, and all these bony edematous changes are extending medially and centrally and posteriorly. So these are all the bony edematous changes along with the soft tissue edematous changes. So we have seen a case which has got unilateral pars edema, pars fracture, and soft tissue bony edematous changes. The T1 vibe has also helped us see that there is a pars defect on the other side as well, which does not demonstrate bony edema or soft tissue edematous changes. And this is where the T1 vibe is not helpful, because T1 vibe cannot comment on the bony edema. It can comment on the bony anatomy. Whereas the T2 fat saturated can help us know that if that particular area where there is a fracture on T1 vibe, if that demonstrates bony edema or not. Next, we looked at these coronal sequences of pars, and these also pick up the anatomy quite well, particularly from the point of view of bony edematous changes and the pars defects. Next, look at the CT examination. So it's quite common that is in these young patients we employ limited CTs because we have the MRI information. So we don't need to do the whole CT. We just do the limited CT at the level of the abnormality to look at the bony changes, bony anatomy, and any particular changes of healing on the CT examination. So now looking at the CT examination, this is the sagittal reformat and this is the axial sequence. And then when we look at the level of the pars defect, on the left side, this is the pars defect. There is gap within the pars defect. So as we go across that, so this is the pars defect, the outer edge. And as we come centrally, this is the pars defect with gap within it. There's a bit of bony hypertrophic change and a bit of remodeling changes in the posterior element, and this seems to be extending medially. So we can see here these changes are extending medially into the lamina, and all these changes are extending medially all across the lamina to the region of the spinous process, and there is spina bifida sort of variant here where this is not fused. Now coming to the other side, this is this side, and coming to the other side where we had seen a less prominent pars defect. So this is the pars defect on the other side, some bony irregularity change on this side as well. But overall, most of the abnormalities centered on the left side with pars defect, with gap, with bony remodeling changes, an unusual orientation and extension of the pars fracture more centrally and medially into the region of lamina. So as I already mentioned, pars fractures are very, very common in young athletic population, adolescent population. And this is one of the grading which is used for pars fractures, and where 0 is normal, 1 is stress reaction, which is marrow edema on the MR examination. There is no cortical fracture. Now in type 2, which is grade 2, there is incomplete fracture, and typically the fracture line is seen in the inferior cortex of the pars. Whereas in 3, there is acute complete fracture. So there's a complete fracture. And in the grade 4, there is chronic complete fracture. This is fracture non-union or developmental defect. So this is an example where the patient has got pars stress changes on the MRI examination, and when the CT examination is performed at the same level, we can see a small incomplete pars fracture. And this is how the incomplete pars stress fracture looks on CT examination. When this becomes full thickness, that changes the grade of the pars injury. So I think with that, gives a good idea about the pars abnormalities.